Hello friends. Today I am going to discuss an important childhood infection, tetanus. Our learning objectives are the etiology, mode of infection, pathogenesis, clinical manifestations, complications, diagnosis, differentials, management, and prevention of tetanus. Essential of diagnosis for tetanus include a non-immunized or partially immunized child, history of skin wound, spasm of jaw muscles, that is trismus, stiffness of neck, back, and abdominal muscles, with hyperirritability and hyperreflexia, episodic, generalized muscle contractions, and the diagnosis based on clinical findings and immunization history. Tetanus is caused by Clostridium tetani. It is a gram-positive, obligate, anaerobic bacillus. It is motile, and form a terminal spore. The vegetative form produce a potent neurotoxin, tetanospasmin, also known as tetanus toxin. Normal habitat for Clostridium tetani is soil, dust, and alimentary tract of various animals. In unimmunized, or incompletely immunized child, infection occurs after contamination of a wound by soil containing clostridial spores. Most commonly, it is a penetrating wound by some dirty object such as a nail, splinter, broken glass piece, or an unsterile injection. Tetanus may also be associated with animal bite, abscess, ear piercing, chronic skin ulcers, burns, compound fracture, frostbite, gangrene, or an infected insect bite. Neonatal tetanus usually occurs in infants whose mothers are not immunized. Typically, there is history of home delivery and dye handling. Now friends, with the help of this diagram, I will discuss the pathogenesis of tetanus. In the infected injured site, tetanus spores germinate into vegetative forms. These tetanus bacilli multiply and produce tetanospasmin. Clostridium tetani is not a tissue-invasive organism and remain localized at the injured site. Tetanospasmin binds at neuromuscular junction and enter the motor nerve by endocytosis. Tetanus toxin also diffuse into the circulation and bind at distant muscle groups. Tetanus toxin undergoes retrograde axonal transport to the cytoplasm of the alpha motor neuron of the spinal cord. In the sciatic nerve, transport rate is about 3 to 4 mm per hour. The toxin then exits the motor neuron and enter the adjacent spinal inhibitory interneurons. Here it prevents the release of the inhibitory neurotransmitters gamma-aminobutyric acid and glycine. Thus tetanus toxin blocks the normal inhibition of antagonist muscles, on which voluntary coordinated movement depends. As a result of this, affected muscles sustain maximal contraction and cannot relax. In addition to above, the autonomic nervous system is also rendered unstable in tetanus. Now friends, I will discuss the clinical manifestations. Tetanus is an acute spastic paralytic illness. It is broadly classified into two types. First is the generalized tetanus, which include the childhood tetanus, and the neonatal tetanus. Second type is the localized tetanus, in which cephalic form is important. Patient with generalized tetanus, usually present with trismus or lockjaw. This is due to masseter muscle spasm. Early symptoms include headache, irritability, and restlessness, followed by stiffness, difficulty chewing, dysphagia, and neck muscle spasm. Child has a sardonic smile, rhesus sardonicus. This is due to intractable spasm of facial and buccal muscles. Later spastic paralysis extend to the abdominal, lumbar, hip, and thigh muscles, and the child assume an arched posture of extreme hyperextension of the body. This posture is called opisthotonus. Head and heels bent backwards, while the body is bowed forward. Only back of the head, and the heels touch the supporting surface. Laryngeal and respiratory muscle spasms may also occur, resulting in airway obstruction and asphyxiation. It's important to remember that tetanus toxin does not affect sensory nerves or cortical functions, so the patient remain conscious and in extreme pain. In tetanus, seizures result from sudden, severe, tonic contractions of muscles. There is fist clenching, flexion and adduction of arms, and hyperextension of legs. Without treatment, seizures may remain for a few seconds to a few minutes, but as disease progresses, these spasms become sustained. Triggers of these spasms are usually a touch, light, or sound. In tetanus, there may be dysuria, urinary retention, or forced defecation. There may be also fever of up to 40 degrees centigrade, because of sustained metabolic energy consumed by the spastic muscles. Now friends, the autonomic effects of tetanus include tachycardia, dysrhythmias, labile hypertension, diaphoresis, and cutaneous vasoconstriction. It's important to mention that tetanus paralysis becomes more severe in the first week after onset, stabilizes in the second week, and then ameliorates gradually over the next 1 to 4 weeks. Now friends, I will discuss neonatal tetanus, which is also known as tetanus neonatorum. It is a generalized tetanus, and typically manifest within 3 to 12 days of life. Early symptoms include feeding difficulties, inability to suck and swallow. This is associated with hunger and crying. There is spastic paralysis, or diminished movements, stiffness, and rigidity to touch. Typically, the lips are pursed, and infant is unable to open mouth. Eyebrows are arched, and spasm of facial muscles gives a sardonic grin. The baby is restless and irritable. Spasms with or without opisthotonus occur within 12 to 24 hours of first symptoms. During spasm, there is flexion and adduction of arms, clenching of fists, and hyperextension of the lower extremities. In neonatal tetanus, umbilical stump is usually dirty. Now friends, localized tetanus is the painful spasm of muscles adjacent to the wound site. It may precede generalized tetanus. Cephalic tetanus is a form of localized tetanus which involves bulbar musculature. In this case, there is usually a wound or foreign body in head, nostrils, or face. However, it may be associated with chronic otitis media. Clinical features include retracted eyelids, deviated gaze, trismus, rhesus sardonicus, and spastic paralysis of tongue and pharyngeal muscles. Now I will enumerate the complications of tetanus. These include aspiration of secretions and pneumonia, pneumothorax and mediastinal emphysema, laceration of mouth and tongue, intramuscular hematoma, rhabdomyolysis with myoglobinuria and renal failure. Long bones or spinal fractures, secondary infections, decubitus ulcers, venous thrombosis, pulmonary embolism, iatrogenic apnea, cardiac dysrhythmia, asystole, unstable blood pressure and temperature, long-term cerebral palsy, decreased mental abilities, and behavior problems. Now friends, diagnosis of tetanus is mainly clinical. In an unimmunized, or incompletely immunized child, a history of a wound or bite, the characteristic facial appearance, stiffness, trismus, rhesus sardonicus, and muscle spasms, help in the diagnosis. In tetanus neonatorum, home delivery, dye handling, unimmunized mother, approximately 7 days old, failure to suck, trismus, and muscular spasms, and clear sensorium, point towards the diagnosis. Laboratory studies in tetanus are of little value and are usually normal. However, leukocytosis may be present due to secondary infections. Blood sugar, serum calcium, cerebrospinal fluid, electroencephalogram and electromyogram are all normal, except intracranial pressure may be raised due to spasms. Gram stain of Clostridium tetani is positive in only 30% cases. Now the differentials of tetanus include parapharyngeal, retropharyngeal, or dental abscess, brainstem encephalitis, bacterial meningitis, rabies, strychnine poisoning, tetany, epilepsy, narcotic withdrawal, and birth trauma. Now friends, I will discuss the management of childhood and neonatal tetanus. It's important to designate a separate room or location for tetanus patient. Place the child in a quiet, shaded or dark area. Protect him or her from tactile and auditory stimulation. And clean, debride any devitalized tissue, and remove any foreign body from the wound. In tetanus patient, human tetanus immunoglobulin should be given as soon as possible to neutralize the toxin, which is present in the circulation, to prevent its binding with the neural tissue. Because once the tetanus toxin starts axonal, retrograde transport to the spinal cord, it cannot be neutralized. Usual dose of tetanus immunoglobulin is 500 units intramuscularly or intravenously, depending upon the available preparation. In addition, administer age-appropriate tetanus toxoid-containing vaccine, 0.5 ml intramuscularly, at a separate site. Friends, tetanus disease does not induce immunity. Children without a history of primary tetanus toxoid vaccination should receive a second dose 1 to 2 months after the first dose, and a third dose 6 to 12 months later. In neonatal tetanus, immunize the baby with complete primary series of vaccination following the disease. Now if tetanus immunoglobulin is not available, then horse anti-tetanus serum ATS or anti-tetanus antitoxin can be given. Usual dose is 10,000 units, half is given intramuscularly and half intravenously. However, serum sickness is an important side effect. In tetanus, antibiotics should be given to kill the vegetative Clostridium tetani, which are producing the tetanus toxin. For this, penicillin G, 100,000 to 200,000 units per kilograms per day intravenously, 4 to 6 hourly is given for 10 to 14 days. Metronidazole 15 mg per kilograms 8 hourly, is also equally effective. Erythromycin and tetracycline are alternative drugs in case of penicillin allergy. For muscle spasms, sedation with diazepam should be done. Initial dose is 0.1 to 0.2 mg per kilograms, intravenously, every 3 to 6 hours, then titrate the dose upward as needed, then sustain on the effective dose, for 2 to 6 weeks. Also add chlorpromazine syrup, 10 to 15 mg per kilograms per day, to control fits. Other alternatives for sedation and muscle spasm control include midazolam, phenobarbital, paraldehyde, magnesium sulfate, dantrolene, baclofen, and levetiracetam. For autonomic dysfunction control, magnesium sulfate morphine can be used. Now friends, drugs which are used to produce sedation and muscle spasm control can result in respiratory depression. If mechanical ventilation is available, this is less of a problem. Otherwise, monitor the patient carefully. Adjust the medications to provide maximal spasm and autonomic dysfunction control while avoiding respiratory failure. However, if laryngeal spasm is impending or threatening, then mechanical ventilation should be provided. Early tracheostomy is preferred because endotracheal tubes provoke spasms and exacerbate airway compromise. Now friends, in tetanus, it's important to give adequate nutritional support and maintain fluid and electrolytes balance because both these steps enhance the chance of survival. Monitoring of a tetanus patient is important, but with care, as not to trigger a spasm. Patient's vitals, oxygen saturation, apneic spells, and intake output records should be kept. Lastly, adequate nursing care is crucial in the management of a tetanus patient. Posture changing, frequent suctioning, mouth, eyes, skin, bladder, and bowel care, all should be done very carefully, as not to trigger a spasm. Friends, in the end, I will discuss some important points about the prevention of tetanus. Active immunization, with tetanus toxoid, is the mainstay of prevention. If an older child gets some wound, active and passive immunoprophylaxis depends on previous immunization status and the severity of wound. Children with unknown or incomplete immunization status are managed differently for clean minor wounds and contaminated serious wound. For clean minor wound, tetanus toxoid containing vaccine is given. Tdap vaccine is given to children less than 7 years old and to 11 to 18 years old, who have never received Tdap vaccine before. However, TD vaccine is given to children more than 7 years age or 11 to 18 years old, who have received Tdap before. On the other hand, for wounds contaminated with dirt, feces, saliva, punctured wounds, avulsions, wounds from missiles, crushing, burns or frostbite, are managed similarly with tetanus toxoid containing vaccines Tdap or TD plus tetanus immunoglobulin or intravenous immunoglobulins or ATS. Children who are immunized or have received 3 or more doses of tetanus immunization are also managed differently for clean minor wounds and contaminated serious wounds. For clean minor wounds, give tetanus toxoid containing vaccine, Tdap or TD vaccine, only if it is 10 years or longer since last tetanus toxoid containing vaccine dose. While, in case of contaminated wounds, these Tdap or TD is given only if it is 5 years or longer since last tetanus toxoid vaccine dose. 3 important points to mention include: always give tetanus toxoid after a dog or other animal bite, whatever the immunization status or wound type. Second, tetanus immunoglobulin should always be given, for a tetanus-prone wound, in a HIV patient. Thirdly, tetanus toxoid can be given concurrently, with tetanus immunoglobulin or anti-tetanus serum, but in separate syringes, and at widely separate sites. For prevention of neonatal tetanus, following strategies should be done. Delivery should be conducted in a hospital. DIEs should be properly trained to use aseptic techniques. Baby should be immunized following disease. Mother should be immunized during pregnancy, by 2 injections of tetanus toxoid, 4 weeks apart, in the second trimester of pregnancy. Last injection should be given, at least 4 weeks before delivery. If mother has been immunized previously against tetanus, then 1 injection of tetanus toxoid during pregnancy is sufficient. Antibodies transferred to the baby from mother protect against neonatal tetanus.